Hi, my name is Cleavon Shand. I'm a practice educator and senior radiographer at Sheffield Teaching Hospitals. Today we're going to learn a little bit about dental radiography. So our learning objectives today are to explore dental radiography and radiology, position patients comfortably for intraoral radiography, recognise general guidelines on patient care within dental radiography, understand the difference between periapical radiography and bite ring radiography, understand intraoral positioning techniques, assemble holders and imaging receptors, use the STH paralleling technique. We're going to talk a little bit about the different teeth we have, starting off with the incisors. So the incisors are the front teeth. That image on the left is just a single root. So usually on an x-ray, your incisors will only have one root. So you can determine based on looking at the x-ray if it was an incisor or not. So in this case, these teeth here, they're flat, they're at the front of the mouth. It would indicate it's an incisor. Canines are situated at the corners of the dental arches and they are sharp, pointed biting surfaces. Their function is to grip and tear food. There are 4 canine teeth in both primary and permanent dentitions. Once again, have a single root. They usually have longer roots in comparison to the incisors. So it's easier to differentiate between the incisors and canines. Moving on to the premolars. So unlike incisors and canines, they have a flat biting surface. Their function is to tear and crush food. They are unique to permanent dentition, which has 8 premolars. Now, this here is the premolar here. Although on the x-ray it looks like it only has a single root, in actual fact, there are 2 roots which are superimposed on top of each other. So just bear that in mind. It will appear as one, but in actual fact, there's kind of one behind it also. Molars. So molars are the largest of the teeth. They have a large flat biting surface. The function of the molars is to chew, crush, and grind food. There are 8 molars in the primary dentition and 12 in the permanent dentition. If we look at the 2 outer images, you can see there are 1, 2, 3 roots. On an x-ray, usually you're only going to see the 2 roots. So I'm just going to go back a slide, and this image here, this is a molar here. It looks like there's 2, but if I was to shift the angle of the x-ray tube, it would reveal the 3rd root. So this image here is of a tooth on its side slightly, just so we can reveal all 3 roots. So you may have a request that comes through and says, yes, we want this molar x-raying, but if you could add a bit of lateral shift of the tube to reveal the other root, so we can demonstrate all 3 roots. Palmar notation is a dental notation used by dentists to associate information to a specific tooth. It utilizes 4 different bracket shapes to denote each of the 4 quadrants and the tooth in question. The mouth is divided into 4 sections called quadrants. The numbers 1 through to 8 are used to label each of the teeth in all 4 quadrants. The numbering runs from the center of the mouth to the back. In adults, there are 32 teeth. Teeth numbered 1 and 2 in each quadrant are called the incisor. The 3rd tooth is called the canine. Numbers 4 and 5 are called the premolar. Numbers 6, 7, and 8 are called the molar. The 8th tooth, also known as the 3rd molar, are also known as the wisdom teeth. So we have 1 and 2 would be the incisor, or in the primary teeth for pediatric, we have A and B would be the incisor. Then we have 3 and C would be the canine. And then we would have 4 and 5. 4 and 5, which is there, would be the premolar. 6, 7, and 8 would be a molar. So in this case, D and E would be your premolars. We have the brackets, which represent the quadrant of the tooth. So this bracket would represent the left upper quadrant. This bracket here would be the left lower quadrant. This bracket here would be the right lower quadrant, and this bracket here would be the right upper quadrant. The left upper quadrant is also known as the maxillary left quadrant. The lower left quadrant is also known as the mandibular left quadrant. The lower right quadrant is also known as the mandibular right quadrant, and the upper right quadrant is also known as the maxillary right quadrant. So for intraoral radiography, the patient should be positioned comfortably in a dental chair, ideally with the occlusal plane horizontal and parallel to the floor. For most projections, the head should be supported against the chair to minimize unwanted movement, to avoid repeat investigation, and to lessen patient discomfort. The patient should always be watched throughout the exposure to check that he or she has followed instructions and not moved. To assemble the bite wing holder, the holder must be attached to the indicator or the bar. The ring must be attached to the indicator. The image receptor is then attached to the holder, and the blank side of the image receptor must face the X-ray. Bite wings. The main clinical indications for bite wings include the detection of lesions, monitoring the progression of dental caries, assessment of existing restorations, and the assessment of periodontal status. Bite wings demonstrate the interproximal surfaces of the enamel, the dentine-enamel junction, and the bone levels surrounding the tooth. Bite wings are used to image premolars and molars. There are two types of bite wings, vertical and horizontal. Horizontal is the most common bite wings. The picture in the middle is of a bite wing holder, consisting of the bite block or the holder itself, the bar, and the aiming ring. Bite wing radiographs take their name from an original technique which requires the patient to bite on a small wing of card attached to an intraoral film packet. Modern techniques use holders. Some manufacturers use color coding to identify holders for different parts of the mouth. So in this trust, the red holders are the bite wing holders. The image receptor should be positioned centrally within the holder, with the upper and lower edges parallel to the bite platform. Correct position of the receptor, holder, and tube head will help avoid overlapping of the interproximal contact or spaces of the teeth. Horizontal bite wings are used to show tooth crowns, alveolar crest, interproximal area. Vertical bite wings are used for the detection of bone loss. The posterior teeth and the image receptor should be in contact or as close together as possible. The holder is inserted carefully into the lingual sulcus opposite the posterior teeth. The anterior edge of the image receptor should be positioned opposite to the distal aspect of the lower canine. In this position, the image receptor extends usually just beyond the mesial aspect of the third molar. The X-ray tube is aligned accurately using the beam aiming device to achieve optimal horizontal and vertical position. Each image usually shows 2 to 4 teeth and provides detailed information about the teeth and the surrounding alveolar bone. The main clinical indications for periapical radiography include detection of apical infection and inflammation, assessment of the periodontal status, after trauma to the teeth and associated alveolar bone, assessment of the presence and position of unerupt teeth, assessment of root morphology before extraction, during endodontics, preoperative assessment and postoperative appraisal of the apical surgery, and detailed evaluation of apical cysts and other lesions within the alveolar bone. And finally, evaluation of implants post-operatively. For extraoral views, the procedure should be explained to the patient, including warning them not to move during the investigation, remove spectacles, dentures, earrings, or facial jewelry to reduce the risk of image artifacts. Intraoral image receptor should be positioned carefully to avoid trauma to the soft tissue. The radiographic investigation should be carried out as accurately and quickly as possible to avoid repeat investigation and to lessen patient discomfort. The patient should always be watched throughout the exposure to check that he or she has followed instructions and not moved. To assemble the anterior periapical holders, the aiming indicator must be attached to the side of the holder, then the ring attached to the aiming indicator. The holder should be visualized through the ring, then placing the image receptor so that the dot matches the dot on the card. This is then turned around and placed on the holder so that the blank side is facing the ray. If you look again through the hole, you can see that the image receptor is in the correct place. So the parallel technique is used for periapical x-rays. In this trust we use the blue anterior holders. These are suitable for imaging the maxilla and the mandibular incisors in canines. Diagram B shows 4 small image receptors to image the right and left maxillary incisors and canine. It's here. Diagram D shows 3 small image receptors required to image the right and left mandibular incisors and canines. So here represents the receptor that would be used to x-ray the lower right 3 or canine, and then we'd use one receptor in the midline of the patient's mouth to capture your 1s and 2s of the lower quadrants, and then we would use another receptor to capture the lower left canine or the lower left 3. In this case, we are assembling the yellow holders to look at the left upper quadrant. We hold the holder and then we attach the aiming indicator, and then we attach the ring. Once the holder is set up, we then pick up the image receptor, wrap a card around it, slot it into the holder, ensuring the blank side is facing the ray. We have a look through the hole, you can see the receptors in the middle. Yellow posterior holders are suitable for imaging premolars and molars. The holders in figure A is assembled for imaging the right maxillary premolars and molars. So this holder here would x-ray these teeth here. So it'd x-ray your upper right 4, 5, 6, and it'd also x-ray your upper right 6, 7, and 8. If you set the holder like so in figure B, it would image your left maxillary premolars and molars. So it would x-ray your upper left 4, 5, and 6. It would also x-ray your upper left 6, 7, and 8, depending on how you position it in the patient's mouth. Diagram C shows the 2 large imaging receptors required to image the right and left premolars in each quadrant. So that just sums up here. In figure D, the holders were assembled for imaging the right mandibular premolars and molars, and then in figure E, it's assembled for imaging the left mandibular premolars and molars. The holders or extension cone paralleling instruments are colour-coded for easy assembly. So the blue instruments are used for the anterior periapicals, yellow instruments are used for the posterior periapicals. The green instruments can be used to image teeth during endodontic procedures. So if you're having a root canal treatment, patients can come to the X-ray department during their procedures just to ensure the endodontic procedure is satisfactory, so they can be imaged throughout their endodontic procedure. The red instruments are used for bite wings. The paralleling technique is the most reliable technique for taking periapicals, as the image quality is good and distortion is minimal. The film is placed parallel to the long axis of the tooth in question, and the central X-ray beam should be directed perpendicular to the long axis of the tooth. Here represents the image receptor. Here is the long axis of the tooth, and the arrow here represents the direction of the X-ray beam. So you need to look inside the patient's mouth before inserting the film. Is there any particular landmarks? Does the patient have a denture? Does the patient have any teeth? Is there an obvious cyst? Is there an obvious inflammation that might affect the way in which you put the holder in the patient's mouth? So just ask yourself, get used to looking inside the patient's mouth. So at this trust, we use holding devices, which is probably the most superior reference for aiming the X-ray beam and the correct film placement so that the tube head is perpendicular and aimed at the entire image receptor. If we look at the image here, we've got the ring in the correct position. It's superimposed in front of the image receptor, so then we're going to get the picture of the entire tooth. Here, the ring has been incorrectly placed. We're going to have the X-ray beam shooting this way across. But you're not going to X-ray anything. The only bit that you're going to capture on the X-ray is this part of the film. Hence here, we have a cut-off of the roots. So it's important you position the ring and the receptor in the correct place so you have the entire tooth captured. If we look here, the patient's not actually biting down. So you need to make sure the patient's biting down on the holder. This way we can achieve the full length of the tooth and there's no cut off of the roots. This X-ray here represents that. So the patient wasn't biting down correctly. So you need the patient to gently bite down. It's represented here in this image. We've got the holder here, nice and parallel to the long axis of the tooth. We've got the tooth actually in contact with the holder, and then we've got the beam perpendicular to the long axis of the tooth. And then the X-ray would probably look something like this. We've got the crown, and then we've got the apex of the root on. Here is a bite wing instrument. Got to be mindful that the holder and the image receptor is actually facing the correct way. As a student, I was always taught if you hold the instrument in front of you and imagine it being a snail, the holder is the body of the snail and then the ring is the shell. This image indicates that the image receptor was correctly placed. And here we have the blue anterior periapical holder, and here we have the yellow posterior periapical holder. Here we have the endodontic green holder. So the bisecting angle technique is an alternative, so it can be used if it was difficult using the paralleling technique for the patient or they was unable to cooperate. So the image receptor film, which is here, is placed close to the tooth under investigation as possible without bending the film. The angle formed between the long axis of the tooth and the image receptor is assessed and mentally bisected. This is your bisecting angle here. So you bisect this angle, long axis of the tooth, and the angle of the receptor or the film, bisect it, half it, you'd get the bisecting angle, and then you apply the angle of the tube head to go perpendicular through this angle. Due to there not being a holder, you do risk not getting the entire tooth on, and you do risk elongating or foreshortening the tooth, and depending on how the film is positioned. So if the patient applies too much pressure on the finger, they're going to bend the film, so then you're not going to get the true representative of the teeth in question. In most cases, I tend not to do this technique. I'll always favour the paralleling technique. Just going to compare the two periapical techniques. The advantages of the bisecting angle are it's more comfortable, the film holder isn't required, and there's no anatomical restrictions. Disadvantages are there's more distortion, harder to position the X-ray beam, and the film is less stable. Moving on, let's have a look at film faults. As discussed before about elongation, you can have vertical misangulation. This is where the tube angle is too short, therefore the teeth are elongated. You can have foreshortening. Once again, vertical misalignment where the tube angle is too steep and the teeth are foreshortened. You can have cone cutoff. We've incorrectly positioned the paralleling instrument and therefore missing the teeth in interest. So if you pick the wrong exposure factors, you can overexpose. So this is too much KV and MAS. You can have overlapping of the teeth. So if you've got a horizontal shift of the tube, you can have overlapping of the teeth. It would indicate that you haven't actually done your parallel technique properly, as in you haven't got the angle of the tube right. Or you can be underexposed when there's not enough X-raying parameters such as the KV and MX. You can have patient movement, so if the patient has moved whilst exposing. You can have the incorrect sensor positioning. So there's two sides to the imaging receptor. One is to be X-rayed on, whereas the other usually has like a copper dot so that the image receptor can be located. Within this image here, the image receptor was placed the incorrect way. This copper dot should be facing away from the X-ray beam, not towards it. You might even have double exposure. So here I can faintly see a canine there. It indicates probably was X-rayed of the canine, but then it was reused again multiple times before wiping the previous X-ray. So now we've got a set of bite wings superimposed on top of the canine tooth. So make sure your image receptor is blank before using it. So panoramic radiography has become a very popular technique in dentistry. The main reasons for this include that all teeth and the supporting structures are shown on the one image. The technique is relatively simple. Radiation dose is relatively simple. Reasons for OPG requests include dental assessment, dental examination pre-cardiac surgery, chemotherapy patients, periodontitis, and primary bone tumour, detection of abscess, if there's bone pain, any trauma, extraction of teeth, detection of any teeth abnormalities, osteomyelitis, detection of caries, the detection of an infection, lateral cleft. This technique is used extensively in orthodontics to assess the relationship of teeth to the jaw and to the jaw to the rest of the facial skeleton. The main clinical indications include initial orthodontic diagnosis, treatment planning, monitoring treatment progress, and post-operative appraisal. Chest x-rays can be done in this trust's facilities to x-ray the chest within the dental hospital in the event the chest needs to be assessed to rule out any foreign bodies within the lung fields. In this case, there is a crown within the lung fields, so this must have been inhaled mid-procedure. Moving on to silography. This is the radiographic examination of the salivary glands. It usually involves the injection of a small amount of contrast medium into the salivary duct of a single gland, followed by a routine X-ray projection. And we have three pairs of major salivary glands. The parotid glands are located inside each cheek, above the jaw, in front of the ears. Submandibular glands are below the mandible on both sides of your jaw, and the sublingual glands are at the bottom of your mouth under the tongue. Salivary glands release saliva into the mouth through salivary ducts. A free flow of saliva to the mouth is important for digestion and general oral health. The main reasons for silogram requests include a constant abnormal or foul taste in the mouth pain, inability to fully open the mouth, dry mouth, discomfort or pain when opening the mouth, facial pain, and facial swelling. It's a variation on traditional CT. It provides detailed images of the bone and is performed to evaluate diseases of the mandible, dentition, bony structures of the face, nasal cavity, and sinuses. It does not provide the full and diagnostic information available with conventional CT, particularly in the evaluation of soft tissue structures such as the muscle, lymph nodes, glands, and nerves. However, cone beam CT has the advantage of lower radiation exposure compared to the conventional CT. Cone beam CT utilizes a low power medical fluoroscopy tube that provides continuous imaging throughout the scan. The cone beam CT uses a cone-shaped X-ray beam that transmits onto the solid-state area sensor for image capture, producing the complete volume image in a single rotation. The cone beam CT shows both mandibular condyles were fractured here and there. It shows that both mandibular condyles were fractured and displaced medially. There is a fracture through the anterior mandible, here, with the right side displaced lingual to the left. The three-dimensional reconstructed images add clinical value to the report. Post-operative imaging demonstrates reduction and fixation of mandibular symphysis fracture and the displacement and placement of arch bars, which are here. Other alternative and specialized imaging modalities include radioisotope imaging, angiography, fluoroscopy, ultrasound, magnetic resonance imaging. Over to you. Work in pairs and fill in the blanks. You have 5 minutes to do so. Please pause the video. And that's it. That's an introduction to dental radiography. So we've explored what dental radiography and radiology is, positioned the patient comfortably. We recognised general guidelines on patient care within dental radiography, discussed the difference between periapical and bite wings, discussed intraoral positioning techniques, and we've assembled holders. The first thing I want you to do when you leave here today is do some further reading. Write down any notes to improve your understanding of periapical and bite wing radiography. At our next session, we will discuss and share notes, assemble holders again, and practice positioning inside each other's mouths. Thank you. Are there any questions?